Ingrown toenails are one of the most common pathologies I treat in my practice. In this video, I'm going to demonstrate how we remove an ingrown toenail on a patient. The first thing we're going to start with is anesthetizing the toe. Obviously, we have to numb the toe to do this. If not, it's extremely painful, and that's what you can see we're doing here. We're injecting the toe. There's 4 nerves actually that surround the toe, and we have to block or numb all 4 of these toes so that we can numb the toe so that the patient doesn't feel anything. And a lot of patients actually think that we're going to stick that needle under the toenail to make it numb, or they're worried that we're going to put the needle in the tip of their toe to get a numbing feeling occurring, and that's not true. We actually do this at the base of the toe. It's nowhere near the toenail. And the reason we go back to the base of the toe is that's where the 4 nerves originate from that supply the area of the skin surrounding the toenail. And as you can see, we're doing this extremely slowly. When you push the fluid into the toe, the slower you go, the less pain the patient will have. And the reason being is as that fluid comes out extremely slow, it doesn't press on the nerve or create pain, and it gives it a chance to start numbing or stopping the sensation or the transmission of those nerve signals so that you won't have any pain in the toenail. After the toe is numb, the next step is to control bleeding, and we're going to use a tourniquet that goes around the toe. And we want to control bleeding for 2 reasons. One, it makes it for a healthier environment where you don't have a lot of blood dripping out. It kind of gets in the way, makes it dirty. It's hard to get a nice tactile sensation for the area that you're working on, and simply put, you don't want blood dripping all over your room. And the second reason is when we introduce a chemical into the border of the toenail to stop the nail from coming back, that blood can dilute that border, or that chemical, I should say, and allow the nail to reoccur, and we don't want to decrease our chance of that happening. Then next, what we're doing here is inserting a freer to free up the nail plate so that we can get access to it. And then after it's freed up, we go in with a blade to actually cut through the toenail. And that's what you can see we're doing there. We're cutting all the way through the toenail, going back to the area that you would refer to as the cuticle, but we call it the eponychium. And after we cut that, it's time to remove the toenail. And we're using a pair of hemostat. The toenail gets turned and it comes out, and you can see at the base of that, right near the eponychium, those are it's kind of like the matrix cells, and they originate from the skin under the cuticle, but that's a glistening white material, or tissue I should say, and you want to make sure you get all that out. If you leave a piece of that behind, it can create some more inflammation. Now we're going to cauterize those matrix cells with a chemical called phenol. The phenol creates a burn under the cuticle area, and that chemical burn is going to stop the nail plate from coming back. And there's a couple ways you can do this. You can do 2 45-second applications. I traditionally will do 3 30-second applications. And we're using just a typical cotton-tipped applicator. And I try to insert that under the eponychium and get down to our matrix cells. I don't want to get too much of the nail bed because we don't want to burn going out to the end of the toe and burning too much of an area, but you do want to burn a little bit of that so that you kind of can ensure that the nail plate doesn't grow back. And a lot of times this is happening, as you can see what we're doing here. You'll get a flap of skin or a redundant area of tissue where that nail plate was pushing into the skin, and you want to make sure you remove that because it can just become a nidus or a region of infection. And also, you don't want any loose skin hanging around, because after the procedure, when the patient is cleaning it days later and soaking it and applying their bandages, they can pick at that skin, and if you create an unwanted area that they can pick at, it can pull and create a wound. So we're doing these 3 applications, and you can see the patient's not feeling any of this. They're completely numb. And if you followed the technique that I had demonstrated, where we're blocking all 4 nerves And we're also introducing some of that lidocaine and marcaine on the plantar or the bottom aspect of the great toe. And that's because there can be another branch of nerves under the bottom of the toe. And if you don't get that, the patient can sometimes have some feeling. So you want to make sure you block all of it. It makes for a much more pleasurable, if you want to call it pleasurable, but it can be, because the last thing you want to do is have your patient in pain and then they're fighting you and you can't do as good of a job. So we do a really nice job blocking that toe to make sure our patient is not in pain during the procedure. And these are done right in the office. Typically our patients will have them done the same day if it's more of an infected situation. If it's a chronic ingrown toenail where there's no infection, there's no redness or what we call erythema, and there's no purulence draining out of the toe, then we typically will have the patient come back and we'll schedule it at a later date. So now we're putting an antibiotic ointment on. Now, I don't recommend putting this much on at home after you've had the procedure done. This is a large amount of ointment and it can create too much maceration or make the skin surrounding the nail bed moist, and you want to kind of avoid that during the healing process. Although you do want to keep it moist. It is a myth. You don't need to let these air out. You want to keep them moist with an antibiotic ointment, but not that much. I just put a little bit more of an ointment on after the procedure in case there has been some bleeding out of the chemical onto the skin, and that can create a burn, and we want to just make sure we're protecting that area. And then I'll put my gauze bandage on. We'll cut that green tourniquet, remove it, let blood flow back into the toe. And you want to put some pressure on this bandage as you're applying it, because you don't want to put it on too loose because the patient will walk out and bleed into their shoe, and that's not fun. You don't want to ruin a shoe, especially these nice red, white, and blue Toms that this patient is wearing. Sorry, these aren't Toms. These are Hey Dudes. You'd think I would know that by now, as I see shoes every day of my life. So as you can see in this technique I'm using, I'm holding gauze with one hand and wrapping with the other hand, and that allows me to apply uniform pressure as we're putting this on. And that can get a nice compressive dressing, stops the bleeding from occurring. The next step is to put on a Coban material, and that's a self-adhering compression bandage. It kind of sticks to itself, puts a little bit more compression onto the gauze, stops any bleeding from occurring, stays on, it doesn't fall off. It's a nice compressed adherent dressing. The patient will take this off in 24 hours, and then they'll start soaking with warm water and Epsom salts, or they can also use warm water and an antibacterial soap. And then they're going to treat this burn with Neosporin and a Band-Aid for the next 2 weeks. If you have any questions about ingrown toenails, drop them in the comments section below.